Hello, everyone. As part of our Better Outcomes webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar, Assessment of Infants with Neonatal Abstinence Syndrome, also known as NAS. And now, I'd like to introduce you to Dr. Therese Verklin, who is our moderator today. Dr. Verklin is a professor at the University of Texas Medical Branch School of Nursing in Galveston, Texas. She is the co-editor of Core Curriculum for Neonatal Intensive Care Nursing. As well, she is the chapter contributor there. She is a reviewer and editorial board member for a number of professional journals and is also an associate editor for the Journal of Nursing and Health Sciences. Dr. Verklin is a member of the American Association of Critical Care Nurses, the Association of Women's Health, Obstetric and Neonatal Nurses, National Association of Neonatal Nurses, and the Academy of Neonatal Nursing. As well, she is a former board member for the National Perinatal Association. Therese, welcome, and I am so glad to be working with you for this special session, and we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
I sure am. Thank you, Emily, for that kind introduction, and to our audience, thank you for joining us for this webinar for part one of the two-part series on assessment of infants with neonatal abstinence syndrome. Speaking on this topic is a really good friend and a colleague of mine who is at the forefront of this very crucial topic, Dr. Karen D'Appolito. Welcome, Karen. She's currently the director of the Neonatal Nurse Practitioner Program, the School of Nursing at Vanderbilt University in Nashville, Tennessee. Karen has served on the board of directors of the National Association of Neonatal Nurses and was instrumental in the development of neonatal nursing practice guidelines as the chairperson of the NAN Practice Committee. In 2008, Dr. D'Appolito received the Individual Contribution to Maternal and Child Health Award from the National Perinatal Association for her work with drug-exposed infants. She has also developed an inter-observer reliability program, the Neonatal Abstinence Scoring Tool. Her research interests are in the area of infant adaptation and chemical dependency. She's had many publications in these areas and has published on the topic of neonatal pain. Our speaker has disclosed the following, that Dr. D'Appolito is the developer of the Inter-Observer Reliability Program for the Finnegan Scoring Tool. This activity has been approved for one contact hour, and we also would like you to know that this continuing education program is sponsored by Philips Healthcare. And now I'd like to invite Dr. D'Appolito to begin her presentation. Are you ready, Karen?
Yes, thank you, Therese, for that wonderful introduction, and I am ready. And I welcome everyone to this webinar, and we're going to be talking about assessment of infants with neonatal abstinence syndrome. So our objectives for today are to define neonatal abstinence syndrome, to identify the incidence and hospital costs of infants with neonatal abstinence syndrome, and describe the Finnegan scoring tool and how it is used to assess infants with NAS. Okay, so we need to start out with a question here. What is NAS? It's also known as neonatal withdrawal syndrome, and some people today are thinking about changing the name to neonatal opioid withdrawal. And I think the controversy there is that most of our babies are not withdrawing just from opioids, that most of the time it's a polysubstance abuse situation. So they're talking about it, but it doesn't seem like that's going to be a change we'll see in the near future. But neonatal abstinence syndrome, as you all know, is a constellation of both behavioral and physiologic signs that are caused by cessation of exposure to licit and illicit drugs in the neonate. It causes alterations in functioning. We have alterations in your central nervous system functioning, metabolic, vasomotor, and respiratory disturbances, as well as gastrointestinal disturbances. And these are a list of some of the drugs that babies will experience withdrawal from. I want to mention one thing about the SSRIs, and many times if you look in the literature, people will say that babies have withdrawal from the SSRIs, but also in the literature it mentions that it's really not withdrawal. What these babies have is called neonatal adaptation syndrome. And it's neonatal adaptation syndrome because the onset is pretty quick It only lasts for about 2 weeks and it's self-limiting. So these are babies we typically don't need to treat for their signs. So I just want to mention that because you will see both of those things in the literature. So we need to start out by asking the question, what is addiction? An addiction is a chronic relapsing disease involving drug seeking and abuse by long-lasting chemical changes in the brain. It produces uncontrollable craving, seeking, and the use of substances such as drugs or alcohol. And I raise this question because many times we refer to these babies as drug-addicted infants. So looking at this definition, we don't have our babies craving these drugs or seeking them out. So I asked the question, are these babies born addicted to drugs? And based on that definition, the answer is no, that babies are not born addicted to drugs. They have passive exposure to the drugs the mother consumed during her pregnancy. So I really challenge all of us to get away from using the term drug addicted infants, because I think that sends a negative connotation for these babies. And there is also right now a lot of negativism around drug use. So I would challenge us not to use that terminology any longer. So the answer is no, right? They're not addicted to drugs. I just want to give you some idea of what's in the literature about incidence. Um, before the publication of this article in 2015, it was stated that there was one baby born every hour who has neonatal absence syndrome. Now they're saying one baby every 25 minutes, a baby is born with neonatal abstinence syndrome. So, and if you look at the chart here that I have for you, looking at the average length of stay as well as cost for babies with neonatal abstinence syndrome, this is based on one baby, that the average length of stay is 16.9 days. And in babies that have neonatal abstinence syndrome compared to those babies who do not, where their length of stay is 2.1 days, and the cost of babies with NAS in this particular study identified the cost as $66,000 or almost $67,000. And this was per baby, that is. And this is based on a sample of 22,000 babies. And as we all know, there has been an increase in maternal drug use, which results in the increase in neonatal abstinence syndrome that we are seeing in our babies today. And this is just some information from Tennessee. We do have a registry where every baby who's born with neonatal abstinence syndrome or with that diagnosis is reported to our health department. And you can see that even in our state, we have seen a definite increase in the babies with neonatal abstinence syndrome. Just to give you a comparison, that other data I talked about was 2012 data. In 2013, just a year later, we can see that there's a difference in the cost here per baby per admission, and overall for those babies treated pharmacologically with medication to manage their neonatal abstinence syndrome. But this was based on a larger sample. There were about 130,000 babies that they looked at. So I think I point this out because when you're reading the literature, you need to really pay attention to the sample size, because that definitely has an impact on what the numbers will show. But I think we can all agree that babies are definitely having neonatal abstinence syndrome. We see more and more babies in our nurseries with neonatal abstinence syndrome. So it's not a problem that's going to be going away very soon. Just about length of stay, because people talk about length of stay a lot, and there's quite variation if you look in the literature for length of stay for these babies with neonatal abstinence syndrome, and it can range from 8 to 79 days with an average of 30 days. In 2012, the average was 17 days for babies not treated and 23 days if they were treated. And what we do know is that about 60 to 80% of infants with neonatal abstinence syndrome will require pharmacologic management. So length of stay, you're in the literature, they're talking about rooming in. These are some factors that we need to consider to help reduce our length of stay. Rooming in with the mother, standardizing a protocol for management, and having reliability in scoring the babies for their NAS. And a few studies have been done looking at rooming in, and I think it's logical in our minds that babies do better when their mothers are there. And we can see from the studies that have been done that there have been a decrease in the need for pharmacologic management in babies whose mothers stayed with them while they were in the nursery, as well as a decrease in length of stay. So we know that it's important. We need to encourage our mothers to stay with their babies. However, we know how difficult that is for mothers who may have other children at home and mothers who work. So we need to not make women feel guilty if they can't come and stay with their babies. However, we need to encourage that as much as possible. In terms of standardized protocols, and I mention this because we need to have a standardized protocol for assessing babies with neonatal abstinence syndrome, but in the literature they talk about it in terms of treatment, and they find that if you have a standardized protocol and it's actually followed by the nurse practitioners and by the physicians, babies will not require as long a treatment. Here we have a decrease by 1 day, and their length of stay can also be decreased. As well as the weaning process can occur more readily. So standardization is important. I'm not sure how many of you have standards or guidelines that you use when caring for these babies, but it's certainly something that you need to consider. And in terms of the reliability of NAS scoring, I mean, this is very, very important because you know that the score that you give the baby is going to be influential in how the baby is treated. So the scores need to be reliable. There needs to be consistency in scoring. Every item on the assessment tool that you're using should be defined. And you need to establish an in-terms of reliability program for all of your staff so that you know that the scoring is consistent and it is reliable. So in terms of reliability, using the Finnegan scoring tool is achieved when you have two people, for example, who are scoring the baby at the same time. One person is doing the exam, the other person is observing, and you score the babies individually and then you compare your scores. So you're doing two independent scoring, coming together then to look at how you scored the baby, see if there are any differences. We like to see reliability in terms of reliability of 90% or greater, which means you can have a disagreement on two items. However, there'll need to be some discussion about those differences, and the baby needs to get a score that you each agree upon. However, that would not change your interobserver reliability. It would still be maintained at 90% if there were two disagreements. Onset of clinical signs, I just included this because many times people will ask me, well, when can we expect these signs to occur? Well, this is just a general idea of when babies may have signs of withdrawal after being exposed to these various drugs. So I'm not going to spend time on that. I think that's something that you can certainly look at. But one of the things that I think is very important is how the baby presents. It's going to be associated with the type of drug the mother's consumed. Was it a polydrug substance situation? When did the mother take that dose of that medication prior to delivery? Infants as well, their metabolism. Every infant metabolizes drugs differently, so that can certainly interfere or influence when you might start to see signs of neonatal abstinence. And along with that infant metabolism goes the baby's gestational age and the baby's birth weight. And some very interesting things are happening now looking at genetics. And we're thinking that we may be able to get to a point where we'll be able to do genetic testing on babies and determine which babies will have withdrawal, which babies will not have withdrawal, so we cannot keep those babies that will not have withdrawal in the hospital. We can send them home earlier. And in these studies, it's really very interesting. They look at these single nucleotide polymorphisms, the OPRM1 gene, the ABCB1 gene, and the COMP gene. These have all been identified in adults, and they have an association with addiction. So there have been a couple of studies that have been done. This one in particular had 5 hospitals in Massachusetts and Maine. They took DNA samples, and what they actually did, they had 86 babies, and these babies were exposed to methadone and buprenorphine, and they collected cord blood as well as saliva samples from the babies, and they looked at hospital stay as well as the need for treatment, and they found that babies that had the the genes, the OPRM1 gene and the COMP genes, those babies had a shorter length of stay and also required less treatment. So it's very promising that we may get to the point where we will be able to do genetic testing and determine which babies will and will not have withdrawal. So that's pretty exciting stuff. Also, what's very interesting, and this was a study, the retrospective review that was done here in Tennessee, looking at sex and NAS, and they found that males had an 18% increase in odds of being diagnosed with NAS than females. So that's just a little bit of information that you might want to keep in the back of your mind. Just a little bit about testing. I think we're all familiar with testing. We all pretty much use urine, but I want you to know that there can be up to a 60% high false negative rate with urine. And urine is only tells you about the drug that the baby was exposed to at the end of pregnancy or right before the mother delivered, maybe 3 days before the mother delivered. That's what the urine report will tell you. We do know that meconium is much better, and we do send meconium samples for our babies. Meconium starts to develop at about 16 weeks gestational age, so we can get a general idea, a really good idea, of what the baby was exposed to intrauterинely. And many of you may be using umbilical cords, which is really, really good. There's instructions that come along with a kit for umbilical cord sampling. And this is just some information. If you want to find out more about it, there's the website that you can go to. But people have been looking at the comparison between meconium and umbilical cord testing. And so they're looking to see, do we have 100% agreement? And we don't always have 100% agreement. With our barbiturates, there is 100% agreement. With our amphetamines, there's a 97% agreement between meconium and umbilical cords. Looking at cocaine and opioids and benzodiazepines, you can see that there are a little bit differences there. There's 96% comparison with cocaine. However, there was a more prevalent in meconium samples than in the cord blood samples. And we see the same thing for opioids. However, looking at the benzodiazepines, there was a prevalence in cords versus meconium for those drugs. And also the cannabinoids, marijuana, 76% comparison between meconium and umbilical cord testing with a prevalence for meconium. So I think just by looking at this, we can pretty much see that there's a good agreement between using meconium and umbilical cords. However, for certain drugs, there's more of a prevalence to find that drug in the meconium versus in the umbilical cord sample. Hair analysis, I like to include this. We don't really use it, but I thought that's a really cute picture of a baby. So I like to include it just so you can see that little baby's picture. But we really don't do it with babies' hair analysis. We can, however, we don't have a lot, babies don't have a lot of hair, and you need about, you only need about a half a centimeter of hair, but you need about 50 strands of hair in order to do this analysis, and our babies just don't have that. So here we have a little case study. Here we have a baby, baby A, who's a 36-week-old infant, who's admitted to the NICU at 12 hours of age. And the baby has tachypnea, has tremors, has a high-pitched cry, and hypotonicity. And the mother had no prenatal care. This is all the information that you have. So what is going on with this baby? And many of us may jump to the conclusion saying that, yep, this baby has neonatal abstinence syndrome. But is there more information that you need before you can make that assumption? And we need to do a differential diagnosis because babies that are hypoglycemic, have hypocalcemia, etc., can also have some of those signs that we associate with neonatal abstinence syndrome. But if all these lab values are normal, such as the glucose is 96, calcium is 9, the rest of those items are within normal limits. You don't have central nervous system injury, so knowing the APGAR score is very important. And in this particular case, the baby had APGAR scores of 8 and 9. But it's important to consider a differential diagnosis and not just jump to the conclusion that the baby has neonatal abstinence syndrome. So in that little case that we talked about, you got additional information and you found out that the mother's urine toxicology was positive for opioids, for marijuana, and for cocaine. You check with the labor and delivery room nurse, and you find out the mom was in a methadone treatment program or is in a methadone treatment program, and she has been during her whole pregnancy. And the mother has had 3 other children who were taken away from her due to drug use. So given all of this information now, I think we can come to the conclusion that this baby does have neonatal abstinence syndrome. So that's our final diagnosis, is neonatal abstinence syndrome, which we know is a generalized disorder. Babies can have it in response to being exposed to licit as well as illicit drugs in utero and to polysubstance abuse by the mother during her pregnancy. Onset, I gave you some times for onset. Also, what's important is the half-life of the drug. Some of these drugs have a very long half-life. For example, methadone has a very long half-life. So it could take longer for the baby to exhibit signs of withdrawal if the mother's been in a methadone treatment program, for example. And we talked about before the timing of the maternal last drug. And I can't emphasize enough that there's some individuality in terms of how the babies actually metabolize the drugs that they were exposed to. Yeah, I want to mention this, the AAP guidelines for observation. How long should you keep these babies in your unit for observation? And what the AAP says is you should keep babies in the unit for 3 days for short-acting opioids, such as heroin, for example, and 5 to 7 days for babies that are exposed to longer-acting opioids, such as methadone. So I get this question all the time: how long should we watch these babies or keep these babies in the nursery if, for example, the mother has been exposed to methadone? Because the baby may not have signs in the first 3 days, it would be inappropriate to send that baby home. So we would need to keep that baby and observe that baby for at least 5 to 7 days of life, for the first 5 to 7 days. So multiple drug use. What's important here is we need to have accuracy in assessing for signs of NAS, and it's recommended to examine infants with NAS using the Finnegan scoring tool. And I'm sure that's a tool that many of you are currently using. So we're going to focus on the assessment of these babies with NAS using the Finnegan scoring tool. So this is the Finnegan scoring tool, which many of you, I think, are probably familiar with. It contains 21 items, and you can notice that there are different scores that the babies get for the various items. And the scores are weighted based on severity. And this tool was developed in 1975 by Dr. Finnegan, and it was designed to assess the severity of withdrawal in babies. Some of the literature says that this tool was designed to help babies or to help minimize length of stay as well as length of treatment. And I just want you to realize that that's not the goal of this tool. The tool is primarily used to assess the babies for the severity of withdrawal signs that you're seeing in the baby. It's a whole gamut of things that's associated with whether the baby's there for a longer period of time or a shorter period of time. And that also includes how the babies are being treated pharmacologically. So this tool was developed based on 200 observations as well as review of the literature. And today we are still using this tool because it is the best tool available for assessing babies for neonatal abstinence syndrome. So best practice, we need to be reliable in using this tool. We need to be consistent in assessing babies. We need to have definitions for all of the items that are on the assessment tool that we're using. And we do need to establish an inter-observer reliability program. Scoring frequency, initially we need to let the babies transition, and that could take anywhere from 2 to 4 hours after birth. So we want the baby to transition because you may see some of the signs that are typical of withdrawal when the baby's going through that transition period. So we need to make sure that the baby's transition, and then we want to score them every 3 or 4 hours, and treatment begins when the baby has a score on the tool of 8 or greater. And it's interesting because I've gotten a lot of emails and a lot of questions about, well, where did this score of 8 come from? Well, interestingly enough, in 2010, there was one study that was done that looked at normal newborn babies, and they had 102 babies, and these babies were greater than 34 weeks completed gestational age. And they did the Finnegan scoring every 8 hours for the first 72 hours. And then they also, after the babies went home, at 5 to 6 weeks of life, they also scored the babies at 4 a.m., at 8 a.m., 4 p.m., and at midnight for 3 consecutive days. And lo and behold, we find that those babies who had scoring done during those first 72 hours, they had a median score at one day at 5.5, but by the second day, the median score was 7. So if a normal baby can have a score of 7, then it's logical that we would start treating babies for signs of NAS when the score was 8 or greater. Scoring frequency, certainly if there are no signs within that 72-hour period and no treatment is required, those babies could go home at that particular point in time. So one thing that's very important, and many of you may know this if you're using this tool, is the tool is dynamic. It's not static. So you might be assessing the babies every 3 hours, but you need to take into consideration what's happening with that baby during that 3-hour interval between scorings. So that's very, very important. And the inconsistency that we see, this is an example of some of the inconsistency. How do you differentiate between mild, moderate, and severe tremors? And how do you differentiate between a hyperactive and a markedly hyperactive motor reflex? So that's why it's so important to have consistency, because you can ask 10 different people this question, and you probably will get 10 different responses. What we have developed is a yawning and sneezing record that can help you to assess babies during that interim period between scoring. So if anyone in between that period should see the baby sneeze or see the baby yawn, they can document it. And we also have a tool to help us with sleep recording. So again, if the baby's awake and you happen to see that, you can identify that by scoring it on this record. So the nurse who's going to be scoring that baby at that 3-hour point in time can look back at these records, and it'll give her some additional information about how the baby slept, as well as how whether the baby had episodes of sneezing or episodes of yawning. So the items that we're not going to particularly talk about today are the items that are pretty easy to score, and they're listed here with nasal stuffiness, temperature, etc. I think those are pretty self-explanatory, and the score is easily identified on the scoring sheet. The thing I want to spend most time on are those items that are most problematic, and that includes the crying, the assessment of sleep, differentiation between mild and moderate and severe tremors, assessment for tremors when the baby was awake and handled, and awake and after handling. So we're going to spend time talking pretty much about these items that are more difficult and more problematic to assess. So looking at crying, we look at excessive crying. We're going to talk about hyperactive motor reflex, etc. So I don't think I need to name them. We're just going to go right into, for the sake of time, going into assessing these babies for cry, for example. So how do you assess a baby for crying? Well, the baby will get a score of 2 or a score of 3. So if the baby has excessive high-pitched cry, and it doesn't necessarily need to be high-pitched, but if the baby is crying and you're unable, and the baby's unable to self-console themselves in about 15 seconds, and you can't console the baby within that 15 seconds, and the baby continues to cry for 5 minutes while you're continuing to try to console the baby would get a score of 2. So it's based on how long has that baby been crying. So if the baby's been crying up to 5 minutes, but you can console the baby within that 5-minute period, the score will be 2. If it's longer than 5 minutes, despite any intervention that you're doing, the score would be 3, because the baby would be crying greater than 5 minutes. So it's based on how long the baby is crying and whether you can or cannot console the baby during those periods of crying. Sleep is based on the longest sleep period. So what you need to do is have an idea, and that's why it's good to have that documentation, how long did the baby sleep? So you're scoring the longest sleep period that the baby has. So if the baby, and this is after a feeding, so if the baby the baby sleeps less than 1 hour after feeding, they would get a score of 3. If they sleep less than 2 hours after their feeding, they'd get a score of 2. And if they sleep less than 3 hours, they would get a score of 1. So the thing is here, we want to provide the babies with enough time for them to sleep. We want them to sleep during that 3-hour interval if you're scoring every 3 hours. Now, this brings up a concern and a question that comes up many, many times. When should you be scoring these babies? Should you score them before they're feeding? Should you be scoring them after they're feeding? Should you be scoring them after the baby falls asleep and you wake them up to score them? Well, certainly, as we all know, these are babies that you don't really want to wake up once they fall asleep. So the literature does say that you should wake the babies up after they have fallen asleep, but that's something I really don't recommend. What I'm recommending now and what we're doing now is to give the baby half of their feeding before you score them. So they're not hungry. They're not really ravenously hungry. So give them half of their feeding, give them their medication, and then give them the rest of their feeding. And then hopefully the baby will fall asleep so you won't need to wake them up when it's time to score. So you'll score them after you give them the first half of their feeding, you give them their meds, you score them, and then you give them the rest of their feeding. So hopefully that will help because, as I said, you need to make sure the baby has at least 3 hours to sleep or you can't score this item. Okay, the Mara reflex. And we're looking for a hyperactive or a markedly hyperactive Mara reflex. And I think everybody knows what a Mara reflex is. You startle the baby and the baby's arms go out, the hands open, and the fingers, the thumb and the index finger form a C shape, and the arms come back to the body in a very nice slow motion. With these babies, we don't see that slow motion. Many times these babies will have some tremors during the Mara reflex, as well as maybe after the Mara reflex is complete. So if you see that happening, if the baby is tremoring during the reflex, as well as right after the reflex, that would be a hyperactive Mara reflex, and the baby would get a score of 2. If you happen to see clonus during the Mara reflex, repeated beating of the hands, for example, where there are more than 8 or 10 beats, that would be considered excessive clonus, and that would indicate that the baby has a markedly hyperactive Mara reflex. I don't see that very often, but it is very important for you to observe for that kind of activity. Typically, we see babies who are tremoring during that Mara reflex, and they would at that time get a score of 2. Tremors, I always get a lot of questions about tremors. Tremors, we know, are involuntary rhythmic movements of the muscles. And we see tremors in babies, and we need to differentiate in our babies with NAS whether they're having mild, moderate, or severe tremors. And we need to look at these tremors when we're disturbing the babies, actually handling the babies, or at a period when we're not handling the babies. So we're going to first look at disturbed tremors. So this would be a baby who would have mild tremors or moderate to severe tremors as you're handling them. With mild tremors, we define that as tremors of the hands or the feet when they're being handled, and moderate to severe tremors would be tremors of the actual leg or arm. So you're looking at the difference between tremors of the hands and the feet versus the extremity itself, the arms or the legs. So that's how you differentiate between mild and moderate to severe tremors. So if the baby had mild tremors, they'd get a score of 1. If the baby had moderate to severe tremors, they would get a score of 2. Now, for the undisturbed tremors, some people will score babies while they're sleeping and use that as an undisturbed tremor score. Well, that's not appropriate. What we need to do is, after you have handled the baby, you need to let the baby be unhandled or undisturbed for about 15 to 30 seconds after you've handled them. That's when you assess for tremors undisturbed. So if the baby were to continue to have mild tremors, so tremors of the hands or the feet when you're not handling them, the baby would get a score of 3. And if the baby had moderate to severe tremors during this period of time, the baby would get a score of 4. So you actually need to assess the baby for both tremors disturbed as well as tremors undisturbed. So they're two separate items. So you're not giving the baby only one score for tremors. For example, you're not just scoring the highest score on the scoring sheet. They are two independent items. So the baby could potentially have a score of 6 for tremors when you're including the tremors disturbed as well as the tremors undisturbed. Increased muscle tone, I think this is something that's very easily seen with our babies that have NAS. If you pull the babies from a lying position up to a sitting position and you don't see any head lag and the baby is very rigid, that would mean the baby has increased muscle tone, and the baby would get a score of 2 for that item. Excoriation, I know in nursing school we learned that excoriation was a red buttocks, but in this situation we're looking for rub marks. If the baby's active on the sheets, you may see some rub marks on the heels of the feet, on their elbows. So we're not scoring for diaper rash, we're scoring for excoriation on other parts of the body that are due to the baby being active and rubbing on the surface they're lying on. And the question is here, do we continually score this? Because these abrasions don't go away in a day. So we have decided that we want to score it as you see it. So every day the baby has this abrasion, you would continue to score it. And the reason for it is if you stop scoring after you see it the first time, if it should get worse, for example, that becomes a decision that can be controversial between people. I may think it's worse. You may not think it's worse. So what we do is we score it as we see it. So the baby would continue to get a score of 1 if the baby does have excoriation on their extremities. Excessive sucking. We don't give babies a negative score for sucking on a pacifier. We want them to suck on a pacifier. What we're talking about here is that activity that I'm sure you've all seen where the baby attempts to suck on their hands, but they're really not coordinated and they can't do it and their head is going bobbing back and forth. That's what we're considering excessive sucking. So if this occurs three times, the baby would get a score of 1 for this excessive sucking or for these activities that that you see the baby doing. And I'm sure you've seen this activity in the babies. So if you do see it greater than 3 times, you would want to give the score of 1 for excessive sucking. Myoclonic jerks. Many of us have these. Before you fall asleep, your body might jerk. So this would be a myoclonic jerk. If you were to see this in the baby would get a score of 3. You may just see some twitching of the face or of the extremities or jerking of the extremities. That would be a myoclonic jerk, and the baby would get scored for that. However, I don't see this very often in our babies, so it's not something that you're probably going to see often, but it is something you need to observe for. So optimal scoring. So it's important to know those item definitions for every item that's on the Finnegan scoring tool. You need to establish an inter-observer reliability strategy to assure that the scores are accurate. And you have to remember that the scoring is dynamic and it's not static. So having some mechanism to score or document times when the baby is sneezing and yawning and how long the baby is sleeping is going to be important. And I find that if the parents are there, they really like to complete that yawning and sneezing sheet that I showed you earlier. It gives them an opportunity to participate in the baby's care. And they will also do that in terms of whether the baby is asleep or when the baby awakes. So they can help with doing that scoring, but also nurses that happen to see these observations can document it on those scoring sheets, and that will definitely help you as you go to score the babies at the time of the scoring interval. So this is the documentation sheet that we use to determine whether you're reliable or not. As I said, we'd like to see in terms of reliability of 90% or greater. So that means that if you look there, you can have those two disagreements as I talked about earlier, but it's very, very important that those items are discussed between the two of you and the baby get an appropriate score for that particular item or items. So part of your standardized care should be the incorporation of intra-observer reliability. That should be part of your standard. Reliability score should be checked at least once a shift. So you need to plan for that in your daily care of the babies. Work with one of your other nurses and plan on when possibly you might be able to do that intra-observer reliability during your shift. Having a reliable score will definitely help to assure that the baby's getting the appropriate care that is needed. And many hospitals will also do an annual reliability training with their staff to make sure that they're being consistent with their scoring. But doing the every shift scoring also helps to maintain that intra-observer reliability on a daily basis. And that's really what's very important when you're scoring these babies. So in summary, just to say that infants are not born addicted to drugs, as we mentioned. The incidence of NAS is increasing. The length of stay and the length of treatment can be reduced by using things like rooming in, having a standard protocol, as well as doing reliability with scoring, and that all nurses should be trained to reliability in the use of the Finnegan scoring tool, and a plan of care for infants with NAS should include daily intra-observer reliability scoring. So I thank you so much for your participation and for your attendance today, and I will be open to questions at this time.
Thank you very much for that wonderful presentation, Dr. D'Appolito. Just as a reminder, this activity has been approved for 1 contact hour, and you can obtain those continuing education credits by logging on to www.saxtesting.com/BO, and you will need to register on the test site and complete the evaluation form. And then upon successful submission, you'll be able to print your certificate of completion. I have some questions for you from the audience, Dr. D'Appolito. Yvonne asks, do you have any recommendations for a reliable and valid maternal screening tool?
That's a really good question, and unfortunately we don't at this point. The question comes up many times about universal screening of mothers, and that's really controversial because you really need the mother's permission to do drug testing on her. We don't need permission to do drug testing on our babies, but we would need it for the mother. So at this point, there really is nothing. The best thing is to try to get a good history if you can. So I don't really have a good answer for that other than we don't know at this time.
Okay. Maureen asks, if the baby has undisturbed tremors of the arms and legs and also has undisturbed tremors of the arms and legs, is the baby given a score of 2 as well as a score of 4 for a total of 6? Or does the baby only get a score of 4 for undisturbed tremors of the arms and legs?
You need to score each item individually. So yes, indeed, the baby could get a score of 6 for tremors disturbed and tremors undisturbed. So that's very important because I know that many hospitals, and I get many emails about this, are just scoring the highest sign that you see, which would be the moderate to severe tremors undisturbed. But it is important to assess for both tremors disturbed as well as undisturbed. And the reason is because if a baby has undisturbed tremors, that is an indication to us that their central nervous system is highly irritable. And if babies do have undisturbed tremors, once they begin pharmacologic management, that sign will diminish. So that's the first sign that will go away if the baby does have those tremors. So yes, it is important to assess babies for both tremors disturbed as well as undisturbed.
Great, thank you. Mary wants to know, do you do serial meconium testing?
No, usually just one meconium testing is sent to the lab. Realizing that meconium starts to develop at about 16 weeks gestational age. So from that period on, the drugs the mother's been exposed to will appear in the meconium. The thing that's important is make sure you have a good sample. You need about 5 grams of meconium to do the test accurately. The other thing that I want to mention about meconium testing is that if you were to call the lab a day after they receive the specimen, they can tell you if it's a negative sample. What takes longer is to identify each individual drug that may be present or the metabolite of the drug that may be present in the meconium, and that's what takes an additional 2 to 3 days. So I think that's some important information for you to have as well.
That is important information. I actually didn't even know that. I just thought that they had to go in and test the meconium, and then it would come out with what substance was there, not just the fact that that was the meconium was impacted by something. So thank you for that information.
You're
I'm
welcome.
getting a lot of questions about the scoring tool. When you're using the scoring tool, is it appropriate to score both for disturbed and undisturbed tremors at the same scoring time?
Yes, I think we just discussed that. You need to score when you're doing your assessment of the baby, you need to assess for tremors disturbed as well as tremors undisturbed. Those are 2 separate items on the scoring sheet, so you need to treat them individually and score them individually.
Okay. Are infants to be treated after one score of 8 or multiple scores of 8?
Well, according to Dr. Finnegan, you need to have at least 3 scores of 8 or greater. So that's what's in the literature at this point. What we're discussing right now is that if the baby, if the nurse is reliable, so if there's good reliability with the scoring, then you may not need to wait until the baby has a score of 8 or greater for 3 consecutive scoring. The reason why it's a concern is because as the signs escalate, if you're waiting 3, 6, 9 hours before you start to treat the baby, you're going to be trying to catch up. Because the baby's scores will probably be increasing at that time. It might be better to start the baby sooner on treatment, provided though that the baby's score is reliable. So that's the key right there. But the way it is right now, it is documented that you should have 3 scores of 8 or greater before starting treatment.
You make a good point about having reliable scores. Rebecca asked the question, does it help to have consistent providers for the baby with NAS? And I would think it would, so that you would have the person consistently providing the same examination and getting the same result.
Absolutely, Therese. And it's not just one person, because I think it's unrealistic that one person will always take care of the baby. But if there are nurses that really like to take care of these babies, those are the nurses who should take care of these babies. And the more consistency you have in the provider of care, the better it is for the baby, as well as for the scoring.
Yeah, absolutely. Stephanie wants to know, she wants you to clarify the fever range on the scoring tool. Why is 37.2, the bottom range, considered a fever?
Well, I guess I really can't answer that, because that is what Dr. Finnegan identified as the temperature range for babies. I guess I really don't have a good answer for that question.
Yeah, because that is at the high range of normal, but
Yeah,
probably with all
is.
the research she did, it fell into one of those categories.
I guess so, because I mean, it wouldn't be identified the way it is if that were not the case. So we would need to do some additional testing to see if that temperature range needs to be changed.
Yeah, you can do some research on that. Good.
There you go.
There you are. Raquel wants to know, what do you do if the reliability score is below 80%?
Well, if the reliability score is below 80%, then what you need to do is to have somebody rescore who is hopefully more used to doing the reliability scoring and who has a better inter-observer reliability. That person would indeed need to go back and do some review. But at that time when you're doing it and assessing the baby, it would have to be done over with another person to hopefully increase that inter-observer reliability.
Do all infants need to be continuously monitored with EKG and pulse oximetry throughout the duration of stay if they're being treated pharmacologically?
Well, that's probably a controversial issue. I think most babies that are in the NICU, they are monitored. They do have pulse oximetry. But the thing is, these babies are normal, typically normal full-term babies. I think they do it as a precaution if the baby's receiving an opioid to treat their neonatal abstinence. So I think it's just it's a rule that the nurseries have that the babies need to be monitored. But that's something that I think you can talk to your personnel about, to your physicians and to your practitioners, et cetera, to see if that really is necessary for those babies, since they are full-term babies, and what we're medicating them with are very small doses of opioids. I think it's just done as a precaution at this point, and it is a policy of the unit, so we need to follow the policy unless there's a unit change in that recommendation.
How do you recommend overcoming challenges to accurate scoring posed by babies who are rooming in with their moms when you're looking for onset of NAS?
I think the nurse needs to go in and assess the baby in the mother's room. I think it's a good idea for the moms to see the assessment because they need to have a good understanding of what the baby's signs are and why the baby perhaps has the number or the score that they get. So if the baby's rooming in, then you need to go into there and assess the baby. When it's time to assess the baby, there's no need to take the baby out of the room. I know years ago we used to take the babies out and bring them back to the nursery to score them and then bring the babies back, and that really is not necessary. The mothers should be aware of how you're scoring and what you're scoring. So that would be my recommendation.
Okay.
Thank you.
Do you have any sources? Recommendations for evidence-based non-pharmacologic interventions while the baby's going through treatment?
Yeah, there have been several articles that have been written, and I can provide those. But all babies, and I didn't make this point in the talk, is that all babies should have non-pharmacologic strategies applied. So they should be in a quiet room. It should be dim lighting, not a lot of people talking, not a lot of external stimuli. Swaddling the baby certainly is something that we need to do. So all those non-pharmacologic things the baby should have anyway. That should be a part of standard care. There is one, Dr. Grossman recently published an article about just assessing whether the baby can sleep or whether the baby can eat, and that should be assessment enough for determining whether the babies can go home or not. And I really caution us about that right now. I think we need a little bit more evidence to suggest that that's what we should be doing. I think right now it's still important to actually score the babies. But there are references that I can certainly provide that talk about non-pharmacologic management. And as I said, all babies should have non-pharmacologic management from the get-go. And then if they develop signs after that, then that's when the babies might require treatment.
Good. Melissa asks a great question. Do you have any recommendations on how you train nurses to complete the scoring tool so that you can achieve that reliability between raters for the scoring?
Well, what I suggest is there is a program that we have out that might be available that you might be interested in. But I think on your own, what you can do is if you And you can use the definitions that I discussed in the lecture or change the definitions however you want those items to be defined. You can go ahead and do that, and then make sure that everybody understands and is trained in knowing those definitions. And then you actually can do it on babies that are currently in the nursery with 2 people to begin the in terms of reliability assessment program. Many times you can also, if you have a videotape of a baby, you can use that to train staff on learning the inter-observer reliability and to become accurate with it. As I said, we do have a program that is available, certainly not advocating that you purchase that program, but it is available, and or you can certainly devise a program of your own to train your staff to become reliable in using the scoring system.
Absolutely, because it really just takes practice and attention to detail. And people can help themselves, help each other really gain that confidence in scoring babies. How about this one? Do you adjust the scoring at all for the preterm baby suspected of NAS?
Okay, that's a really good question because this Finnegan scoring tool is only designed for full-term babies. And it's very difficult to assess babies just for NAS if they're premature because they do have other medical issues typically. And the other thing that's important to keep in mind is that most of these drugs of abuse, their metabolites are maintained in fatty tissue, and premature babies don't have a lot of fat. So you're not going to see signs of withdrawal as readily in a premature baby as you would see in the normal full-term baby. So right now we are deficient in terms of having an assessment tool for our premature babies.
More research for you to do. Well, we'll take our one last question. How reliable is that scoring tool as infants age?
That's a very good question as well. The scoring tool is only designed to assess babies for the first month of life. So really, it should not be used after the babies are more than a month of age, because they're more awake and they're eating more and they want more interaction. So it's really not a tool designed for those babies. What I do recommend people use for those older babies is maybe the NPAS, which is a pain scale, but it does look at agitation. So that may be helpful in determining what the babies are experiencing related to NAS when they're older. But the tool is just used for babies up to a month of age. So our goal really is to treat these babies in a way so that we get them discharged before 30 days of life. And I think when you have a comprehensive protocol with scoring as well as for treatment, then that definitely can happen. But that needs to be our goal, to try to discharge those babies before 1 month of age.
Therese, thank you so much. And Karen, thank you for your excellent presentation today. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.